Just tell me when we're ready.
Yep, we're ready.
Welcome everyone to the governing body meeting of the Ipswich and East Suffolk CCG, and welcome everyone out who's watching live streaming. I'm grateful of everyone's assistance that they're giving to the vaccination programme that is currently underway, probably one of the biggest logistical programmes the NHS has run in its 70 plus years. And I want to start by saying thank you. Thank you to all of our admin teams, our reception teams, the volunteers, nurses, doctors, therapists, everyone in their contribution to give 7-day service to the vaccination programme locally. Without it, we couldn't be doing it, so thank you. To those of you who've had the jab, and those of you who are waiting to have their jab, it is still the message: hands, face, space. It's really important that we don't blow the benefit of our first jab and potentially contract and spread the virus. So we mustn't be complacent. So I'd urge you to remember hands, face and space. To those of you who've got a booking, thank you. Thank you for getting that booking and participating. You will help yourself, but you will also help others too. So please ensure that when you've got that booking, you arrive on time. Don't be too early, don't be too late. To those of you who are waiting, I want you to know we have a plan. We've got a plan that is delivering. We were planning to deliver the way that we have been going. So we want you to have some faith that we will get round to you. We need you to stay calm. We want you to wait until you have been contacted. And we know that for some, the experience has been challenging. And we didn't want that to be challenging for you. And we know that that can cause stress and distress. But be assured, where we know there are problems, we are working hard to rectify them. And they aren't all in our control. But where they're not in our control, we are doing as much as we can to influence things to change. So please do tell us when you are encountering difficulties that don't appear to be resolving. But please, can we do this in a way that maintains the respect? Our staff everywhere want to help you, but if they can't give you an immediate response, please don't expect that a demoralizing approach to them will get you a different answer. We will be working to help you get an appointment. We've got an unwritten compact as practices, general practices, with our local registered patients to assist you, and that's right and proper. And please realise that all our practice teams, everyone in the NHS, all our volunteers, our public services are going above and beyond to support this vaccination, this national vaccination programme rollout. So bear with us. We know it's going to be a long haul. For those of you wondering why it might not be working, I'd like to say that in the main, it is working. The supply chain that's required to get vaccinations from factories into arms is not simple. Resolution to the issues that can arise are not always obvious. From logistical supply, the fragility of the vaccine, the safety of staff and patients, the impact on our booking systems and rotas, all of these are very, very finely balanced and need a lot of attention and a lot of support. It's an incredible programme, the size of it, the potential impact of it, never seen the like of it. We're working with a higher supply that providers were expecting. So our practices received twice as much vaccine at the start of the programme that they were expecting, but we haven't had pushback from them. They want to get that vaccine into patients' arms. We want you to get the protection that you need. And we know that our practices are working hard in delivering that. We will see some of the impact of it, talk about it later. And practice teams are providing significant quantities of the percentage of the delivery alongside our hubs at the hospitals and the new mass vaccination centre that is just opened at Gainsborough. So once again, thank you everyone for the help you're giving. Let us know when it's not working. We are doing our best to ensure everyone gets what they need when they have the opportunity to do that. So thank you. Can I move on to the body of the agenda, please? So has anyone got any declarations of interest, hospitality or gifts that they want to declare over and above what's there? Fanwell.
Thanks, Mark. Yes, on item number 7 of the agenda, just wanted to alert you to the fact that ISCRI is supporting the Ipswich and East Suffolk CCG with the public engagement for the long-term strategy.
And anyone else with any other declarations? The list of declarations is included in the papers. Shall we move on to the minutes of the previous meeting? Do anyone have any issues with any of those minutes, either accuracy or otherwise? Please raise your hand. In which case we'll have them as a true record. Thank you. And then if we can move on to the action log, item 086, we've got an update today. 107, look forward to future development, so that's complete and on the agenda for later. We've got the integrated performance report 113. Lisa, do we have any update to give there?
So that item's going to clinical scrutiny, Mark. Our lead midwife is coming to clinical scrutiny to lead on a discussion around that.
Excellent, thank you. And the declarations of interest, are we getting any improvement on that?
That's an ongoing action, Mark, with the practices.
So shall we take it off? It's an ongoing one.
Yes, thank you.
Okay, so on into the next item. I think it's traditionally Ed, an update.
Thank you, Mark. So I think you covered the key points I wanted to raise. I just want to put a slide up just to reinforce what you were saying about progress, and hopefully colleagues can see this, but this is the delivery for the Suffolk CCGs, and a lot of our capacity came online in mid-January, and you can see the difference now that we've got that capacity. We're accelerating very quickly in terms of vaccination numbers, and that was our plan, and we're executing that plan. So I think that's a positive slide to share. The only two other things that we'll pick up on the agenda is obviously the whole country, the whole system has been under pressure with the rise in COVID infections that we saw through December, rising up from Kent through into London and Essex and up into Suffolk. We have currently today 184 COVID positive patients at Ipswich Hospital, which then that number's been fairly static, if not reducing in recent weeks. So that's really positive, but still a hell of a lot of pressure on our system, and a really fantastic response from all of the staff to keep people safe and to protect people during this time. And then finally, I just wanted to say about investment in mental health and inequalities. We've launched an Equity in Mind scheme for £300,000 in our two CCGs in Suffolk with Suffolk Community Foundation, which I'm sure Eugene and Richard will pick up later in the agenda on mental health strategy, but this is aimed at particularly the context of mental health inequalities and our BAME communities, and empowering and investing in our local third sector, our charitable sector, to provide service, and we know what an amazing job they do. So a really positive message.
Thank you, Ed. Any questions for Ed on any of those updates? No, in which case, shall we move on to item 6? And I'm very pleased to introduce Hamel, and Fanwell is going to do the key introduction and talk about some experience. Is that correct?
Yes, that is correct. Thank you very much, Mark. I have the privilege to introduce our guest today, Hamel Clark. I know Hamel, and maybe I should have said it earlier. He is also the chair of the Board of Trustees at ISCRI. But in addition to that, Hamel is one of our community champions. And I hope he doesn't mind me saying this, a prominent member of our community. Hamel has been mayor of Ipswich twice. He has been, involved in quite a number of bodies, education, and a lot of other. He even got an MBE, from Her Majesty the Queen. So it sort of gives you an indication of his involvement. But I suppose, today, what we want to hear from Hamel is really about his experience, as a member of the community, but also as a patient accessing our services, and how the pandemic and the current situation that we are in has affected or not affected him. So without saying a lot, I'm going to let Hamel talk about his experiences. Thank you.
Well, thank you, Faniel, and good morning to everyone. I hope after all that I don't let you down. Where do I start? I can start from my experiences in having the vaccination and leading up to that. I was concerned that how long it would have taken me as an 82-year-old Caribbean, how long it would take me to get the vaccination and what effect it would have on me. And after that, how would I react to members of the community questioning me? As far as getting the vaccination, I was pleased that I got it. And surprisingly, it went smoother than I had expected. I just went in, followed the rules that was laid down there, had the vaccination, sat down for the required 15 minutes, then gave an interview to the lady and the gentleman that were there were making a video to go on the website. I think that is what it was about. But the thing that concerns me most is I do still get information and questions about whether we should, as BME people, should take the vaccination or not. And I find it really not only annoying, but surprising that even some young people and people of my generation are still questioning the effectiveness of it and whether they should take it or not. That's the thing that concerns me most.
Thank you, Hamel, for sharing those things. With your experience, how do we look at managing that that conundrum that you've expressed? I mean, you yourself said surprising. It's a surprising question to get, and it's from all age groups. Do you have any words for us?
I was even told that there was a couple of people in the community who, of my age group in particular, who were refusing to have this vaccination, and the nurse from their practice had to go to their house and sit down and talk them through it to convince them that it was the best thing to do. They had it in the end, all right. But I find that a lot of information is being put on the social media. I get it regularly, but I don't read them. I just delete them as soon as I see the heading of them. But a lot of people of my age group do not do that. They come to the conclusion, I believe, that providing it's on social media, it has to be right. It has to be truthful. And that's an area that we've got to work on to break that belief down. And by that I mean the ISCRI and the ME community that has got some influence has got to try and get the message across that it is in their interest to have the vaccination.
And that the emphasis remains on the facts rather than countering the false aspect. Is that your advice? Well, Dean, any thoughts on that? The impact of social media and belief that what's there is the truth because it's there.
Yeah, I mean, this is something that we are, working on, day in, day out, and I'm quite glad that the system has come on board to support us around this. So Amel mentioned in his presentation there that he had, his photos taken and also a video taken, and this is something that we are seeing as really important. Many people in our minority ethnic communities are taking some kind of a wait and see approach because of all the stuff that has been fed, through social media. People are worried about what could or could not happen to them. And I suppose by seeing, people like Amo who are respected in the community, who are trusted, putting themselves forward and saying, I've taken the vaccine, and maybe, we will have a conversation again with him, later on, and he'll be saying, I am okay. There's nothing that has happened as a result of that. Hopefully messages like that will then encourage other people who are hesitant to take up the vaccine. But I suppose alongside that, we are also saying to people, yes, there might be some who are really, sort of saying we are not going to take this vaccine. It's also about, putting forward messages about, like you did at the start, Mike, to say, we still need to follow, the guidance around social distancing, around washing hands, but also just looking out after ourselves so that, we remain healthy, and in case, something happens, at least, you're in the best sort of shape in terms of health. So we need to be pushing those messages in tandem as we are trying to get more and more people vaccinated.
If I could just quickly comment, because I know you're pushed for time, Mark. It's essentially it's a two-sided sort of problem. So in a lot of ways, most of us on this call have benefited from good information, which outweighs the bad information. And there's been a sort of generations of trust that's been lost, which means that there's a vacuum that just gets filled in by the bad information. We are sort of working our tails off to try to counter that, because obviously we are in a bit of an emergency. And so attacking it from everything from mass media to social media. But the absolute key is to get as many trusted voices as Hamel saying exactly what we are saying, so that when we do launch the strategy, that we have the trust of these communities.
Thank you. Yes, the importance of facts first, social and professional leadership together. Lisa, you'd had your hand up.
Well, I was just going to add, so in my experience, when you do take some time for people that are vaccine hesitant to sit down with them and have just a short discussion that explains the facts and helps them to understand how it's not only about them but about their family and friends and the people that they love and the protection that it will give to them, it actually makes a significant difference and does help them to make a more informed decision. But we don't have, within the vaccine centres and the vaccine process, it's such a fast process that there isn't often, people don't feel that they can come and have those discussions with us in those environments. So it definitely is how can we make arrangements so we can have those discussions with individuals that are vaccine hesitant, and it's people from the BAME groups, it's young women I see who are scared about fertility issues, and they just need a bit of one-on-one time, and then they often actually make their own informed decision after that, which is different to the one they had beforehand.
You. And Hamel?
Yes, if I can just come back quickly, anecdotally, I've got two daughters who both works at the hospital, as a matter of fact, but they have had their vaccination. There has been no comeback. So I am trying to persuade them that when they talk to their friends, they must convince them that they have had the vaccination and there hasn't had any repercussions. I'm hoping that spreads around anyway.
And Fanwell.
Yes, I want to comment on what Lisa just said there. One of the things that we have seen is, in normal circumstances, when somebody goes to their GP and they are unwell, whatever the situation might be, more often than not, people listen to their GPs. People take the advice from their GPs. If you're asked to go and get some medication from the pharmacy, very rarely do you have somebody questioning why or the ingredients that have gone into that medication. Yes, once in a while we do get that, but in most circumstances we don't. So some of the work that is being done by people like Juno, we've seen Juno everywhere in the media, in different events, but also just talking to individuals in the community, because again, people trust not only their doctors and GPs, but also to see somebody from your own community who is a trusted person, a doctor, but also saying, look, I wouldn't be exposing myself to this thing if it was as dangerous as you think it is. I think it's also helping. So I think we need to use those voices more so that we can try and convince the doubting people in the communities.
Thank you. Thank you. It's a really good conversation. Those of us who do negotiation with patients, some of us use something called FIR, which is facts, implications, respect, resolve, as a method of trying to remember everything that helps a negotiation go well. And I think that's what we've been describing here. We need the facts. We need to understand the implications. What we need to do is give the respect. We need to give time for the respect, the mutual respect between our professionals and the patients who we're working with and the communities they come from. And if we do that, we can get resolution. So we can hold on to that. It doesn't come, though, without good social and professional leadership. And Hamel, can I thank you on behalf of the governing body for that leadership that you have shown and your willingness to give that leadership. So thank you. And to all of us out there, remember to make time to show respect and to for us to be able to get the facts and the implications understood, and hopefully a good take-up of the vaccination as a consequence. So thank you all for that.
I hope that my contribution has been helpful.
Extremely, and we thank you for it. And if you want to stay as an honorary member of the commissioning group this morning, please feel free. Otherwise, you are more than at liberty to just get on with what you've got planned for the day.
Okay, thank you very much. Thank you.
My pleasure.
I'll leave and let you get on with.
Thank you. Thanks for that, everyone. A good discussion. Shall we segue neatly into Dean and Imran, an update on the strategy for Black and Asian minority ethnic communities and a focus on reducing health inequality.
Thanks, Mark.
Yes, hello.
I'll kick off very quickly, but I think this one is on Dean. He spent months and months writing a wonderful strategy, which is, I don't know how many pages long, but I've had to use 2 printer cartridges, Dean. Thanks. I think you owe me that one, mate. Yeah, this is so the important thing about this is a strategy that's been drawn up separately, but it's not a completed work, and I think that's the key part of this. This is now going to go through a really rigorous co-production phase. So, Dean, I'll hand over to you, probably because my camera's about to die again. Sorry.
Right. So essentially, we can say we started this journey sort of back in June with the first What Are We Missing sort of events, and that was all brought on by the disproportionate impacts we were seeing along sort of socioeconomic and the disadvantaged sort of groups in terms of mobility, mortality, and all the rest of it. But in actual fact, this journey probably started sort of long before that, when all of the statistics that Marmot would bring forward in terms of sort of 5 times sort of likelihood of dying sort of during pregnancy for Black women sort of came to the fore. Unfortunately, what COVID has done is that it's accelerated this process and has just brought it into our society's view. And it's on the back of that we started the conversation with our communities with lived experience to ask them, what are we missing as a system? So in essence, the headlines chime with a lot of the evidence that we have gathered. Essentially, over sort of 117 pages and 300 plus references, the basic principles that have come forth are: 1, what we are about to do needs to be system-wide. So because the social determinants of health make up the majority of the reason that we have poor health, we need to attack this from an ICS, a system-wide space, from everything from police to education, sort of to health, to public health, to every single work stream in what we do. And the reason for that is probably threefold in my mind. The first one is a monetary sort of one. In terms of discrimination, the UK loses about 127 billion per year. If we had a decent sort of inequality strategy, the NHS would save about 12.5 sort of billion. But that's not the biggest reason for doing that. The biggest reason for doing this are twofold. One, as a society, health inequalities just cost us too much. It costs us too much sort of morally, but also in terms of all the key workers that we've been sort of intermittently clapping for over the pandemic. There's a disproportionate proportion that are represented not only by the BME communities, but by the other communities that are disadvantaged sort of by this. So what now? What are we going to do with this strategy? It's been a massive sort of scoping exercise to look at all the evidence sort of from around the world and all the things that we know within our system. So now what we've done is that we've put together a document that will just act as a foundation, because the bit that we are missing is the co-producing voices of these communities who just essentially know better than we do. All of the work streams and things that we've put in place over the years have been well-meaning and in actual fact have been cleverly designed. But the problem in this complex adaptive system that we try to wrestle with and we try to run is that essentially we cannot afford to produce this by ourselves. We cannot afford a lot of the resources and solutions that will be needed to turn this around. So part of the strategy is we're going to set up meetings with public health, get their expertise into the arena, but more importantly, with a lot of our teams with lived experience to get us to where we need to be into pushing this work into the causes of the causes, the upstream problems that cause these issues. So the next steps. The next steps for the draft strategy will be, first we will discuss it within our equality and diversity work stream, and we've set up sort of lots of meetings with public health who are doing actually quite good work within this space. There'll be an immediate path to the strategy, which is to get us out of this this pandemic that we're in, to get the trust rebuilt and all of the vaccination programs sort of going. But essentially the take-home messages are that, one, it's going to be system-wide and sort of comprehensive. It's going to have to be co-produced with our communities and those with lived experience. We are going to have to look at the people that are in most need, and it's not just the BAME community. To be fair, it is the traveller community, the Roma community, those people in the inclusion sort of groups like the transgender population that can have anywhere between 30 and 50% suicide sort of rates. So it's going to be a big job. And as a system under pressure, we are going to probably struggle to do it. It's going to essentially need quite courageous leadership, which Ed has definitely shown. Is going to need a system-wide approach, but we are going to have to invite a lot of the communities seldom heard or never asked into our spaces, into our places of influence. It's not just about money. Resource can include time, influence, sort of, and the like. But over the next coming months, we will be rolling it out, and then we'll be asking sort of for your help, for your leadership, for your courage, so that we can all sort of be that change that we all wish to see. But yes, watch this space.
Anything additional that you wish to add, Imran? It's quite succinct from Dean.
No, I think Dean's hit the nail on the head. As with all these things, writing a strategy is the easy part. Making it come to life and changing cultures, and we're talking not just cultures in our communities, but cultures within our statutory organisations and voluntary sectors. And the other key part that Dean's touched on and touched around is this idea of targeted universalism. You know, we need to support everyone. This isn't particularly about one group, but by bringing everyone up, we get the benefits. And I know Dean has particularly said it's not just about money, but unfortunately there is this element of having to sort of target some of our financial incentives to recognise that actually to achieve the same outcomes in these groups, we do need to differentially invest financially and resource-wise to get those same outcomes, and that's what it's about. It's equality of outcomes. I think Clanwell's got his hand up, Mark.
Yes, indeed. I just wanted to come back on that last statement that you made there, Imran, and an issue that I did raise at our Health and Wellbeing Board, that when Public Health introduced their report, that unless we are prepared to change how we view what is fair currently to what is actually really fair, and move the resources to meet that challenge, then we will have another report telling us the same things again in another 5 years' time.
Mark, can I just just final point just on that. There's a really key element to this, because what we see always in crisis is each individual organisation bunkers down, and then when they get a challenge, they'll put up some support, be it financial or resource support, but it's scattergun, it's not strategic, it's individual pots of money or individual pots of resource. And what we're asking for, and then I think this is what Dean's done in his work, is actually say, let's bring this together, let's do this together. We know that if we all come together and work, actually our resource implications will be less, because we'll be sharing, but we'll also be getting a universal message and a universal package of support, and that's absolutely key.
Yeah, and hopefully when we come to item 11, that gives us an opportunity through the alliance and a partnership agreement. Fanwell.
Yes, thanks Dean and Imran for that presentation. I think for me there's a word, Dean, that you mentioned in there, which is trust, and that is the key in terms of taking this work forward. So I have been part of the conversation for the better part of 10 years in terms of addressing inequalities, and I suppose it's not fair to say the system has been ignoring that. Stuff has been done, some of which I've personally been involved in. When an issue happens, people will find an underspend here and there, and they'll try and address that issue. But in the main, this is something that is actually put off communities to say, where is the real commitment to address this? Because when you put in an underspend, it's actually not part of your long-term strategy. You address it at that time, and then another crisis comes up, and you move on from there. And I think we are in a unique space right now to really embed this work into business as usual, because this is what our communities are calling for. I suppose there is much more impetus now, given some of the communities that have come forward and said, we want to be part of this. As part of what are we missing, but also moving forwards. Some people have come forward and participated as our community champions. They've inputted into some aspects of the strategy that Dean and Imran have been working on. But that has also created an expectation to say we want to see how the system is going to change as a result of this. So we are in this situation where our communities are looking at us to say what is going to be different this time around. And so I think we need to evidence that, otherwise the trust is going to be lost, and it will be very difficult for us to regain that. I mean, just finally, I wanted to point out, and I think it's following up on what Imran has just said, we are currently in a crisis, and it is important that we address the immediate issues in a crisis, which is what we are seeing the entire system doing. But by so doing, we should also make sure that we are learning from those immediate things that we are doing as a way of informing the long-term work. Because my worry is, at the moment, if you ask anyone across the system, they'll say we are doing this and we're doing that, but none of that is long-term. A lot of the work that we're doing is to just address the crisis. So we need to be thinking on a long-term basis, and I hope that this strategy is something that can be used across the system to plug that gap. Thank you.
Thank you, Fanwell. Richard?
Really heartened to hear the progress that's been made, gentlemen, and also just what you said, Dean, around other groups that aren't always represented, particularly the transgender community, which actually is more of an issue in Suffolk than I think possibly we would give credit for. Just some practical questions, I guess. So I think you said, Dean, rightly, there's a balance between us writing a strategy kind of here and then going out and engaging, co-producing that strategy with those very groups, such as the transgender community, that we want to hear from, and then balancing that, as Fanwell said, against the practicalities of we need to be seen to be taking action, not waiting a long time to do that. So just your reflections, I guess, on what do you feel is the timescales for trying to move this forward? And how do we balance that kind of getting something versus actually doing that co-production piece that we've all committed to?
Okay. So in terms of sustainability and scalability, we essentially have to do both. we have to admit that as statutory organizations, we do not have the resource and the capacity to actually deliver a lot of this. It is going to have to be delivered by community organizations, by individuals, by the voluntary sector. If you're going to ask them to deliver it, they have to own it. At the moment, we all as a system are running at or above capacity. And for each pound you put into the voluntary sector, you get 11 sort of back. So that is the key. The reason that we have to engage, and the reason that we have to be a little bit patient as sort of at the start to rebuild that trust, is that unfortunately we just don't have the capacity to deliver it by ourselves. We may know the right answers, but without social prescribing, personalization sort of care, engaging the voluntary sector, getting people to do things for 10p on the pound, for example, you have to engage because they're surprisingly motivated. So that's the first reason. The second reason, unfortunately, is all about the inverse care law. So we are pushing for something called collaborative place-based sort of approaches. So if you went for a pure place-based approach, unfortunately, that makes inequalities worse. So over the last 10 years, the Marmot report says that the gap has widened. And that's not because statutory organizations haven't been doing anything. It's that the unfortunate thing is that when you do something without engaging and co-producing with the communities that most need it, it opens up sort of access, and the gaps sort of widen. So yes, and then the last bit is, in actual fact, some of these voluntary and community organizations are actually faster and more nimble and more reactive than we are. So in terms of getting the message sort of out there, some of the work that ISCRI has been doing in getting sort of literature translated and into a culturally sensitive form, they can turn around in half an hour. Whereas we struggle with that. So for all these reasons, one, we have to co-produce. In terms of timelines, we are meeting as an equality and diversity group this afternoon. We have set up sort of meetings with Stuart sort of and the team. There's some money coming down through councils and through public health about engaging a lot of these sort of groups. So we're going to sort of put those together. And there'll be about 15 to 20 of these small working groups that are made of people with domain expertise and lived experience from the communities, from the voluntary sectors, and also from our statutory sort of organizations that will sort of try to embed themselves in all the places that need sort of levering. So it will be moving at pace. The putting together the strategy and the academic evidence bit of it, that took a long time because we're in the middle of a pandemic and I can't type quickly.
Thank you, Dean. I think there's a couple of things. Within the Integrated Care Academy, there is a priority around inequality and trying to achieve equality. So we can look at how there's a synergy between this strategy and what the academy could support. There is a clear sense that the communities who need this are activated, and what they need is the resource to make the work happen, allow the work to be done. And I think that is going to be the challenge back to us. And it is part of our strategy that we support communities through Connect. Not wait for it to get into integrated neighbourhood team level, but to work through Connect to prevent that need escalating. So it shouldn't be beyond the wit of our teams to align those two things and think our challenge is how will we go about ensuring that resource is delivered. Imran, did you have a final point before we?
Yeah, just a final point around the co-production, Mark, because I think statutory organisations have done co-production or tried to do variations of co-production for years, and so I think in some realms it's not seen as something that can be done quickly or done effectively. And actually, if we look at the vaccine trials, the COVID vaccine trials, we've shown, that's shown how quick you can do things quickly if you're not slaves to a certain sort of way of doing things. And that's the key thing about the strategy. This is a living document. It's not something that, we're going to have to work all the way through before we start implementing all the way along. This is about co-producing it and delivering it. So the block is just that initial starter. It's not about waiting till we've got an entire co-production body or group set up. This is live. This is real. And so, that hesitancy we shouldn't be worried about, because it's going to be owned, delivered by and policed as well. That's the important thing. Right the way through the PDSA cycle, this will be co-produced. So reassurance.
Thank you. So thank you both, and everyone involved in that update is very welcome. And without it, it's an exemplar of an approach to managing inequalities, and we need that. So thank you. I'm going to move us on to item 8, Suffolk Mental Health Transformation Update. Richard.
Thank you, Mark. And it really segues from the 2 items that we've just had, if colleagues have had a chance to look through the paper. So, as always, just bringing an update on the mental health programme that has continued at slightly reduced pace, but still a huge amount going on. I think the first thing to say is that we have taken a decision as a group of partners around the 2 alliances to extend the timescale out to September 2021. That takes account, I think, of the pressures that all partners are currently facing and the significant redeployment of staff onto the mass vaccination and the response to the pandemic. But notwithstanding that, as you'll see in this paper, there's still a lot of work happening that we're keeping going. So I'm pleased that particularly the paper talks around the important role of the VCSE sector and some of the work that we're looking to do. And I'm joined today by Eugene and Jason, who are on hand to answer any questions, and it's very much their work that they've been leading over the last couple of months. So just before I just touch on the VCSE section, the first element that we're looking for approval from the board today is to an important development that we want to continue with, which is the individual placement support service, which is an employment service integrated within our community mental health teams for people who experience severe mental health conditions to get them back into and continue within employment. We commissioned Essex Partnership University Trust, so EPUT, in January 2019 to provide this service, and the contract was due to expire imminently. We're looking today to reach agreement that we extend that through a contract waiver. You'll see the financial sums within the paper. The reasons for that is that it's a beacon site held up nationally in terms of good practice, EPUT, for this service. There's no concerns currently over its performance. Paul is nodding. And EPUT were also awarded a 5-year contract to provide this service ongoing within Essex, and there was no competition for the service. So, to be honest, we think it's absolutely appropriate to go down this route with a service that's already working, and they're already providing a fantastic offer. So, effectively, it's about continuing with that. So, that's the first piece that we're looking for an agreement today on. And then the second element, really, as I said, segues into the significant work we're doing with the voluntary community sector across Suffolk, and we're looking to go even further with that. So you'll see within section 3 that there's 3 interrelated elements that we're developing. The first is, it sounds quite technical, but we're developing a procurement framework with the VCSE sector, and this is really partly as a result of feedback from elements of the VCSE sector about the complexity of dealing with the NHS, and particularly where we get a last minute thing that we push out and we say we need a response, within a few weeks or a month. Actually, we want to take the time now with developing with the VCSE sector an appropriate framework that some of our VCSE providers can actually get onto this framework, and then it makes it much easier for us to commission from those organisations through appropriate due diligence when we get opportunities that arise. And the first ones that are looking to arise is not without delay is the crisis cafes and safe havens that we're looking to develop with the VCSE sector across Suffolk, and that would be the first things that we'd be looking to do, and you'll see details of that within the paper. So with the support of the governing body today, and when we present this in the West tomorrow, We're looking to move at some pace now to develop that with the VCSC community and get crisis cafes through that in March as the first work. And we've been given funding from NHS England specifically for that purpose, that we'll be looking to push through that. The second element Ed has already alluded to in his opening remarks is we've also working with Suffolk Community Foundation. We're looking to award £330,000 through around six projects of approximately 50k out to the VCSE sector in Suffolk, which will fund those projects over up to 2 years, focusing on older people with functional mental illness. That came out as one of our key areas through the JSNA work that we did a couple of years ago. People from our BAME community, which we know where there is particular issues around mental health and emotional well-being, and then people with complex emotional needs, so particularly personality disorder, eating disorder and psychosis. So this is just the start, I think, linked to that framework I described, but we were very keen to get a move on and not wait for the framework to actually get out, a bit like Fanwell said, what are we doing right now? This is something we can be doing within a matter of weeks or months to really make a difference to those particular elements of our community. The timeline you'll see at figure 1, we have extended it slightly, so we're actually now saying mid-March for responses to come in, and we'll be looking to award the funding through in late May. If we can do it quicker, we will, but it's that balance between giving the right support to the VCSE community to get bids in versus speed of getting them out. And then the final piece, and I'm really pleased to be bringing this here today, is during the first wave of the pandemic, you'll recall that we commissioned Suffolk Mind, working with NSFT to provide a VCSE response effectively to patients who are some appropriate patients that are being discharged from secondary mental health services into a Suffolk Mind service. And this really builds on the Suffolk Night Owl service, but during the daytime now, Suffolk Mind have been providing a service to that cohort of individuals, predominantly virtual, but obviously, hopefully, fingers crossed, as we start to come out of the pandemic later in the year, there will hopefully be some face-to-face service element as well. And they are looking to expand it to younger people, 18 to 25, and older people. It's predominantly being working age at the moment. We're looking to gain agreement today to extend that. It's at the moment being a pilot. We're looking to extend it for a full year worth of funding via a contract waiver, and again you'll see the financial details within the paper. So Mark, I'll leave it there. That was a very quick canter through. The paper's hopefully self-explanatory, and the recommendation at the end give a very clear outline of what we're looking to get agreed today.
Yeah, thank you, Richard, and thank you for the succinctness. So if we move to the agreement of EPUT for individual placement support first, were there any questions that anyone had on that? I think my own, not so much a question, but an observation really is around how we ensure performance isn't just measured in how many people are there, but also the how improving performance through using some of the strategies that we've just been discussing in the inequalities paper is embedded to try and improve that performance to the maximum, would be my observation to add in. So we're happy with that proposal from EPUT. Jane? That was a quick hand that went up and down.
It was. Sorry, my comment was more general because there's a question in the chat about the finances overall. So, but just to say that the overall financial package that's presented in this paper, we have been through. We've worked with Richard's team on this, and it is all in line with our expectations about investment and the mental health investment standards. So sorry, that probably wasn't at the right point.
Don't worry, Steve. I didn't try and get it through without talking to Jane. Don't worry.
So the second one, noting the further proposals, which I think we are all very pleased to see come forward, and as Fanwell will have said previously, see that they're not hindered in coming forward because the rest of the plan is being staged back, that we can get on. So Fanwell?
I just wanted to comment on the VCSC framework, which we're coming up, and I think this is something that should be commended. I suppose my only comment on that, and it's something that I've discussed with Jason and his team, and I hope that it's sort of being taken on board. We've got the next bit, which is around the VCSC small grants process. And what we tend to find, and I'm hoping that this is going to be the case, is you do have these very tiny groups that are sometimes not even constituted, but they are reaching out to communities that, some of our established sort of mental health organizations don't reach to. So you find out that, you've got groups working with our traveler communities, our Roma communities, or even, in terms of the elderly, we've got, people who are providing Meals on Wheels to elderly people, sometimes sort of, cultural specific types of food. Now, a lot of these organizations don't see themselves as mental health providers, even though the people that they are working with would need some of these services. So as we are sort of delivering this, we need to firstly look at ways of bringing them in so that we can tap into that expertise, because traditionally they will see a funding pot from the Suffolk Community Foundation and they just won't go for it because they don't see themselves. So the language that we use is going to be critical. And then also making sure that as we are developing the framework, that we tap into them as well, because if we said we want organizations who deliver mental health services to come forward and input into our framework, they will never come and be part of that process because they don't see themselves as that. So again, we need to, reach outside of the usual mental health providers to some of those groups. Thank you.
I agree with that entirely, Panwell. And I think it's not mental health, it's emotional wellness and emotional well-being. And I think we need to be as broad as we can be in terms of what we mean by that. And I'm sure I don't know, Jason, if there's anything specific you wanted to come back on, Panwell, on that point.
Yeah, I'd love to. And thank you. Good morning, everybody. I think it's really important. And I think part of the idea of the grant is to try and bring some more known mental health providers in the voluntary sector together with some of the smaller groups and vice versa. I think Fanny was quite right in saying that people don't see themselves as delivering mental health support. So this is our first chance of promoting what we're doing and starting to talk to these groups. And part of the process will be around self-evaluation, peer evaluation, and we're going to work really closely with all the applicants on developing these projects, and obviously alongside our GPs and NSFT. So this is a collaborative approach to supporting the sector. It's not just about getting funding out there, which is great, but it is about trying to build a community response to mental health.
Thank you. So any other questions? So we've got the 4 recommendations. Are people happy to support them? Anyone not happy with those? We've made some additional comments and we've got approval. So thank you very much. Shall we move on to the item 9, the Suffolk and North East Essex Memorandum of Understanding on Controlled Drugs. Is it Maddie and Lisa?
Yeah. Yes, thank you. So I'll be very brief. This is simply a refresh of a previous document agreement. It sets out the responsibilities and accountabilities of NHS England and of the CCG team. And for us, the important points are that Lisa may wish to come in, is our lead. We have representatives in the regional forums, and our medicines management technicians are trained and fulfil their functions for practices in relation to the destruction of controlled drugs. So I'll leave it there. Very happy to take any questions with Lisa, but this is a continuation of the arrangements that we currently have. This is a refresh. Thank you.
Okay. And anything else you wanted to add, Lisa? No?
Oh, I don't think so. I think it's quite straightforward. Thank you.
Yeah. Lorna?
I just wanted to say that, there's been this opioid epidemic in the States, and one of the things that I think that they've demonstrated, which is really important, is that patients understand and GPs understand how long post-operative narcotics or simple opioids need to go on for. and that the process of disposal of those and the knowledge that the patients need to have about how long to go on for is very important to try and stop any other members of the family helping themselves to things, or for the patient to develop any form of addiction. And I think it's very clear that that's something that I think we should perhaps think about whether we need to add something in there about that.
I think that's a really good point, Lorna, and I agree. I think there's ongoing and further work that can be done with the clinical teams and with patients and the public about understanding of these drugs and, as you say, their appropriate management and destruction. So I totally agree with you, and I think as soon as we possibly practically can, we will get to that.
Okay, any other questions? So an additional note to look at, Lorna, and otherwise receiving and approving with that additional addendum to be considered as well amongst all of the others. Thank you. Paul, we're moving into the procurement board.
Thank you, Chair. I'll be relatively brief. I'll take the paper as read, only to say that this paper has also been to the various subcommittees of the CCG and has been approved and is finding its final way around to governing body for final sign-off. I think this is something which has been agreed for some time, and I think it's been a while coming into fruition in terms of other priorities around COVID and other things to bring it to board. I think broadly the paper sets out a proposal to bring the expertise of 3 CCGs together and broadly look to review procurement programs, make use of local expertise that we do have, ensure really standardized approach to how we make decisions and add to transparency on how we actually make those decisions. I think it's really important to point out that at this stage, it does not remove any of the CCG own accountability for procurement, and that's really quite important, an important point. And just to put a little bit of context around this paper and to look into the future, we've just had a bit of discussion around voluntary care sector and mental health, for example. And if you cast your minds back, and I know it feels a long time ago in terms of the long-term plan, but there was some interesting proposal within the long-term plan suggesting that the current legislative framework was essentially incompatible with a partnership and integration agenda as we move forward. So as a system, we have moved really at pace and be looking to innovatively look at the way we procure. But inherently within that, at the moment, there is a risk that the both don't match. So actually the decisions what we make are really quite important in terms of making sure we do the right thing and don't expose ourselves to a variety of challenges through the procurement route. And the other point to make sort of more broadly is that does not mean that that procurement will cease in the future. Procurement will carry on, and the best value for money and outcomes will clearly come to the fore. And I think this is really a precursor to make sure that we learn as we go along and make sure we do captivate all the expertise and the resources to make sure we make the right decision moving forward and keep us safe from a legal point of view. So I'll stop there and I'm happy to answer any questions.
Thank you, Paul. As you say, we've been able to review this in a number of other avenues. Does anyone have any additional questions that they wished to raise? No. So are people happy to approve the recommendation then? I don't see any challenge to that, so thank you very much. Now moving on to item 11, the Ipswich and East Suffolk Alliance Partnership Agreement. Ed, do you want to open on this, or would you prefer I did?
I'm very happy for you to do so, Chair.
So again, this is a paper that we have introduced. We've been developing our strategy as an alliance over some time and working with our clinical executive as to how the roles of the clinical executive and the governing body move and support to alliance working alongside all of the partners within the alliance, statutory and voluntary sector partners, and those providing services locally. So this alliance partnership agreement is really reflecting the developing trust, transparency and collaboration that the alliance has been developing over that time, and helps move us from a contemplation phase of a group of willing partners wanting to do the best for our population through that collaboration, and moving them from that contemplation to a commitment. And so that we're saying yes to the respect that we show each other for making good decisions and how we go about supporting our integrated neighbourhood teams and the teams that do the work for us with our patients on the ground every day. So I'm hoping that the governing body will accept that this is the right step forward and contains the right information, and look forward to hearing any other questions. Maddie, did you want to add anything else?
Thank you. So I was just going to emphasise, I feel this is a really important step in our journey as an alliance. We have a strategy, we have a plan, but this is an agreement between the partners which is being signed by the leads of the organisations. And please say that several signed documents have already been received, so that's very positive. You will note in the document that there are a few gaps that we still need to fill, including some discussions with wider partners in our district and boroughs and in our wider community in particular. But I think we need to just crack on. It's really important that we show leadership and move ahead with support for the agreement whilst we continue to evolve as an alliance. So I wholly support this and very grateful to Liz Maloney for bringing forward this draft. Thank you.
Thank you. And any questions from members of the governing body on it? Imran.
Not a question really, just a sort of next step. I think there's a really important bit about making sure we share this with our clinical directors and our PCN leads so that they're aware of direction of travel and can understand how it all weaves in and fits together.
Indeed, and you know, we know that there's more change afoot within the NHS, and what we don't want is the work that we've done to be having to be done something different. We think we're on the right track. This is really helping to cement that, and the inclusion of clinical directors from a primary care perspective will be part of that move. So yes, thank you. Any other queries on it? So happy to receive and approve that one. Thank you very much. And we're going to move now, Lisa, to the Ockenden Maternity Safety Report.
Thank you. So the report gives us really an overview of where we are with at both our trusts and within the LMS of the essential actions that we have to put in place following the Ockenden report. So I think the first part of the report details the background. This is the first report that we are expecting from the investigation into the Shrewsbury and Telford Trust, but there were so many emerging trends that came from the review that it was felt that there were some essential and immediate actions that needed to be shared with all maternity services across England. So the key issues in section 2 details the areas of compliance that we have been asked to benchmark ourselves against as an LMS and with each provider, and essential actions, and an action plan has to be developed to ensure compliance with each 7 areas. Section 3 just talks through the implications for our Suffolk and North East Essex system, and there are some responsibilities with the LMS. We are now being asked to make sure that we have a quality surveillance framework as a new role for the local maternity system, which will be feeding into our integrated care system quality surveillance group. So we're doing a lot of work to make sure that we have improved our oversight of the safety and quality agenda rather than just the transformation agenda. Excuse me. There's a number of areas under 3.5, from 3.6 to 3.11. It details the areas of development for our LMS, and there's probably one that I need to pick out specifically, which is under 3.10, which is, it says one site is yet to 100% comply with saving babies' lives care bundle. I just wanted to assure the governing body that this is one of our hospital sites which are currently amber on one element of the bundle, which is element 2, the fetal growth restriction. And actually the obstetricians have reviewed the evidence and implemented a local pathway following the Royal College of Obstetricians and Gynecologists guidance. And they are actually offering higher risk women more serial growth scans than is in the recommendation for the bundle. So actually we are very confident and assured by the pathway that the hospital has taken, but until we have gone through the process of getting it signed off by the clinical network and the CCG, we've had to mark them as amber at the moment, but it's completely acceptable for an alternative pathway to be developed. So the next steps, our trusts have to send a detailed assurance report to both the LMS and NHSEI by the 15th of February. You may pick up in the paper, it said 15th of January, sorry, but due to current circumstances, it was postponed until the 15th of February. And then the evidence has to be uploaded to a national portal in March, and we will then start site visits to test the evidence that the trusts have submitted. So I think we're in a good position. A lot of work to do both at system level and at provider level, but I do feel confident that we'll be able to deliver on those essential actions. Thank you.
Thank you, Lisa. So happy to take any questions for Lisa on this. I've got one observation to make, which I think I have raised with you, Lisa, and also both medical directors at our trusts around how we develop the culture of safety and improvement to manage reducing the SIs, not just in how we report them, and how we embed that. So it's not something demanded of frontline staff, it's actually demanded by frontline staff. And I think that is a really fundamental difference to in some ways to this approach within the Ockenden and recommendations within the Ockenden, which, as we know through experience with mid-staffs, Morecambe Bay, Shrewsbury, it's all about what is the culture of reporting near miss, not waiting until we've got a stack of SI before it's seen that major action takes place. That's just my observation, and hope that we can do something along that line, not just in maternity, but for the general culture across everything. Lorna.
Just a comment as well, in the key issues, number 7, informed consent. It says all trusts must ensure women have ready access to accurate information, including maternal choice for caesarean section. And we should be careful when we're asking for or looking at caesarean section rates to make sure that that's not conflicting what we should be with the correct thing that we should be doing.
Mm-hmm. Yeah, I would totally agree. I think there has to be obviously a discussion with the clinician and the woman around the decision-making process for caesarean section.
Thank you. So with the additional work that Lisa was talking about and the observations we've made. We're happy to receive and note the report as it is. You've said about going in and having a look once things are established. Would it be worth us having a chance at some point, whether it's through clinical scrutiny and reporting onto an action log here, how that has been and felt?
Yeah, definitely. So that currently to test the Ockenden assurance is currently planned for the spring. We are planning some quality assurance visits into the trusts to look at maternity services more globally, and certainly we'll keep clinical scrutiny updated on that.
Okay, thank you. So with that in mind, we'll move on to the finance, performance and scrutiny part of the agenda. We've noted a system response to COVID-19, specifically the vaccination programme. Are there any specific things within the integrated performance report that officers want to bring up? I was hoping that we might be able to note the report and move on, given the time pressure that we've got, but there may be some specific changes or updates that need to be specifically brought to our attention. No? Okay, Lorna?
I was just going to make another comment. I think that during this time, I don't know how it's been, particularly in Ipswich, but certainly within Norfolk, I think that the ambulance service has really stepped up, and we have spent a lot of time criticising them, but I think they've been absolutely exceptional during this COVID period.
Thank you, Lorna. And we've had some positive discussions and changes in pathways involving our ambulance service, and great work with our Suffolk GP Federation as well, and the provision of mutual aid between Colchester and Ipswich with the help of the ambulance service. So we too would be very also like to say thank you for those for that flexibility. Paul.
Yeah, Chair, I'm more than happy if you wanted me to say just a couple of things on as an overarching position statements to in regards to performance that would help.
Okay.
I think the first thing I'd say is up until now, certainly, and the system carries on to be really focused on recovery despite the challenges that we're actually facing at the moment. And had we been not in wave 2 of the pandemic, and I would have been reporting that actually when you looked at performance for November, SNF will have achieved 84.9% around cancer standard in 62 days, which is phenomenal in terms of where we've actually been. But clearly what has happened in December is that we saw an increasing number of COVID patients within our hospitals. Ed's already alluded 184 patients in Ipswich, and there was a significant more numbers than that in Colchester. That meant a significant pressure on staffing, significant pressure on elective activity, and essentially their ability to manage the emergency and the complexity of what that means to managing patients safely within a hospital site. The thing that I would say in terms of the learning that we have done, we've moved extremely quickly to work with our private sector partners to make sure we are safeguarding urgent elective activity and also maintaining cancer services. So again, we've had recent conversation and enacted various contract clauses to make sure we maximize the capacity we've actually got. Invariably, that will mean, unfortunately, that moving forward, beyond to December, we will start seeing dips in performance, and we will report those as we move forward. But essentially, I would echo the comment that's been made. The system and all partners are working incredibly hard to make sure that the NHS remains open as the patient actually need it as we move forward, and that's the only thing I would comment on.
Thank you. Pete.
Yeah, just to give a little bit of context to what Paul has just said, is that the volume of cancer referrals from primary care has not dipped to the significant degree that it did in the first wave. The volume of fast track referrals has continued at good levels, so it actually makes the trust performance even more impressive, given the pressure, particularly on diagnostics, CT and MRI, endoscopy. Again, it's been able to continue, unlike the first wave of the pandemic, even at reduced capacity. The only other thing I'd point out is from the December figures that John Reynolds circulated, outpatient firsts are down, but I think that reflects our move to using advice and guidance as a default mechanism rather than traditional outpatient models, which again I think is an innovation that's been introduced more quickly to the benefit of all due to the pandemic.
Indeed, and I think that it's important that we can reflect that, because the combination of first referrals and advice and guidance is really important for us to know. And as you say, Pete, the benefit of advice and guidance is that we can support patients with quicker decision making as a consequence, rather than waiting for what might be some time before them being able to get what could have been advice and guidance. Any additional points to make? So shall we just note the rest of the performance report as it is presented? Thank you. And if we can move on to the governing body assurance framework, William, anything particular that you wanted to bring out?
Only to say, Mark, that there's two new risks, and we've talked about one in detail, which was the COVID vaccine program, but the other one was, as everybody knows, is that E-East has been put into special measures, which I don't think we've touched on just yet. Other than that, I got nothing else to add. Okay,
thank you. And anything, Ed, from an E-East perspective, or Lisa, that would be helpful for us to understand?
I guess there's two parts of that question. So the performance of East has been absolutely fabulous, as Lorna has referenced, during the festive period, which is the high risk period, and during the pandemic. So we're seeing sustained performance due to the for lots of reasons, but also the capacity that, as commissioners, we negotiated for them. They've got significantly more capacity on their own than they did this time last year or 2 years ago. So I think it would be good to come back to a governing body to look at that aspect. The special measures aspect was around the cultural issues within the trust, and particularly a culture of bullying and various poor practices that is also being worked through. So I think we're seeing the trust move forward operationally, but culturally has a lot of work to do, and Lisa and colleagues are working with the CQC and East and other partners to drive improvements there. So, but potentially we could have a more holistic view of the trust to capture those two elements and their progress against them. But Lisa, do you want to add to that?
No, I think you've said it all. Actually, there is system meetings jointly with all stakeholders and East to track the performance against the CQC recommendations and must-dos, and they have a lot of national support, particularly in the area of improving their culture and their leadership capacity and capability. And they're making some great progress. The proof of the pudding will be in the sustainability of that and what the workforce and the front line say in the months to come. But certainly the approach that's been taken around the support given to them from the national team feels really good. So just waiting to see how it all plays out, really.
Thank you, Lisa. And good to hear that the national support has been so effective. Thank you. So shall we move on to freedom of information, Amanda? Amanda's frozen. Amanda, did you want to talk about freedom of information?
Thank you, Chair. Sorry, I've got bad reception at the moment. Hopefully you can hear me okay. So I'm going to take the report as read, but it takes us up until the end of December 2020 in terms of the freedom of information requests that we've had to respond to. And as you can see from the report, we are averaging around 20 requests for various information every month, which has been a slight decrease during the pandemic. But having said that, we continue to still respond to all requests within the 20 days, which I think is very good news. The request for information has really been very different since we've been through the pandemic. It has been the usual types of information, albeit just at reduced numbers, but very happy to take any questions.
Thank you. Any questions for Amanda? I think it's explanatory, isn't it? So thank you for that. So next is the terms of reference for the joint CCG's collaborative group.
Thank you very much, Chair. So very minor tweak made to the terms of reference when they were reviewed, and for ease, those changes are shown in red. Tiny.
Yes. So any questions to that one? Thank you. We'll receive and approve those then. Thank you. And then on to minutes of the meetings. Any questions about those? In which case we will endorse them. And our next meeting will be Tuesday, the 23rd of March. So over to questions. I think we said that there were no questions before the start of the meeting. Have there been any additional questions since we've been on air?
So we've got one additional one here, Mark. This is from Alan Rhodes. Can you ensure that the inequality strategy work dovetails with the parallel strategies of the provider trusts?
Okay, so Dean, any thoughts on that?
Absolutely. There is no way to do this.
Can you adjust your mic, Dean? Sorry.
Yes, sorry. There is no way to do this but to do it system-wide and holistically. That's the whole point of the inequality strategy. It is complex. It's multifaceted. There's lots of work to be done around intersectionality and sort of all the rest of it. So, in essence, if we look at the public health and annual report, it tells you not only the complexity of the people that are going to be impacted by this, but it goes from everything from health to education to policing. So yes, I'm fairly confident that we won't leave any stone unturned or any person unimpacted.
So I suppose what we would like to see is that as you say, the strategy is adopted as a system, and that partners are asked to align their strategy to that of the system. Is that what we want to see?
Yes, absolutely. And to be quite sort of honest, it's not a strategy that's been sort of just come from us. We have sort of read and perused sort of all the strategies within sort of our ICS, looked at a lot of Anna Chris work in public health, who are sort of experts sort of on this. So it's not being sort of created sort of in a vacuum. And some of the strategic principles that we are trying to nuance and bring would be around the co-production piece, but also around the outcomes piece. So a lot, unfortunately, of our system partners, there's a lot of activity, a lot of well-meaning activity sort of going on that don't quite get to that outcomes piece. So 3 take-homes: 1, co-production, 2, sort of outcomes and not activity, and then the last bit is really about sort of reflective leadership. In the inequality space, all of us want to do better, but we have to reflect on the fact that some of what we have done hasn't quite come off, hasn't quite worked, and what is the missing ingredient that we need for it to work. So it's not going to be a huge sea change of what people are already doing. We're just trying to add the nuance based on the evidence that we've pulled together of what actually sort of works to deliver outcomes and not just activity.
Okay, so I think at some point, in response to Alan's question, is how we bring this strategy through an ICS process that engages all of the partners, and specifically in trusts, engages the non-executive partners particularly. So maybe taking an opportunity to use the chairs group of the ICS might be a helpful step at an appropriate moment.
Mark, we have a couple more questions that have come in, actually. Is it okay to answer these now? So 2 additional questions have just been received in the last couple of minutes from Anthony Dooley. And the question is as follows: why do you never refer to income inequality when discussing health inequalities, and refer to the 10 years of austerity?
Okay, and the other question?
The question is, again, also from Anthony Dooley. This one's to Ed. What's your reaction to the fact that ESEC failed on 5 of its target consistently? What's your reaction to the fact that ESEC failed on 5 of its targets consistently is the question. That also from Anthony Dooley.
Okay. Which one first?
Come in on the first one.
Inequality, yeah.
So yes, I did a part of the complexity and the multifaceted nature of health inequalities is socioeconomic, and my memory might not be serving me right, but we did mention the socioeconomic sort of aspect of it. In a lot of ways, if we want this to be an all-weather strategy, I cannot get political. We really do have to focus on the disadvantaged, the inclusion groups, and the socioeconomic disadvantaged groups, and work with what we have. I think as an anchor institution, and also working with our system partners, we can do everything within our sphere of influence to change things and to help those that are especially impacted by economic sort of inequality. And unfortunately, it's not just about money; it's also about access and voice and co-designing services. And then just one last thing to say about economic sort of inequalities. We are going for what we call targeted universalism, or how Marmot would call it proportionate universalism, which essentially means that sometimes for every patient, I may have to invest a little bit extra time, a few more medications to get their blood pressure right. And it's the same with communities and populations. Sometimes you have to invest a little bit more time, a little bit more effort into getting them up to an equitable level. So in a lot of ways, a lot of communities will be benefited by this, but I can only work within, and I think our organizations can only work within our sphere of influence, and the political side of things we try to stay away from.
And a recognition really that those wider determinants of health contribute 80 to 90%, depending on who you look to, in health outcomes. So it's not just income inequality, but income inequality does influence. But education maybe if you were looking at a hierarchy, education is what helps people find the jobs that allows them to have the roof over their head, that protects them and their health. So, education may be even more important. A reaction to ESEC?
So, I mean, any provider that doesn't meet its standards is disappointing to us as a board. I think ESEC gets singled out because it's not an NHS organisation, so a particular focus on that, but there's a number of organisations that haven't delivered their standards. We're obviously continue to work with them and improve over time. We have seen improvement, but we're very disappointed that they haven't delivered all their standards. Of course we are.
Thank you. Okay, so on that basis, we'll close this meeting. We do have a part 2, so we will move to that. Can I just say to everyone watching, thank you for your attention, thank you for your questions, and we'll meet again in March. Thank you.